Welcome to A Window on SAHMRI, where we take you inside South Australia's independent not-for-profit health and medical research institute. Each episode, we get to know the people driving our life-changing research, getting into what motivates them personally and how their work is delivering a brighter, healthier future for all.
Deb, you've been in haematology for decades. How has that field of cancer research evolved over that time?
Yes, decades is correct. It's evolved amazingly. So I started as a tech, working and training in haematology, so doing diagnostic haematology. In that stage, we knew a lot about the sort of malignancies that we saw in haematology patients, and there were good treatments that saved some people, but not very many. These days, we know so much more, and part of that's technology-based. So, we can now do gene sequencing. We can develop specific drugs to target the specific parts of the cancer that we can now understand. So, leukemia used to be a disease that was lymphoid or myeloid, so sort of just different cell types, but we knew nothing about it. And you hope that blunderbuss full of chemotherapy had an effect. These days we can be so much more prescriptive about what sort of disease a patient has and therefore what sort of treatment they can possibly get. So we've managed to complicate our lives, but understand a hell of a lot more about the sort of disease we're dealing with.
And it used to be more of a blanket death sentence
Yes.
for people, and now that's not often the case.
It's still the case in some subtypes. For some subtypes, we don't have too much in our armoury. But for particularly, so, if we talk about the poster child, well, two I could name that I've worked in, chronic myeloid leukemia, we now know enough about the exact alteration that causes that disease so we can target it. And we would now suggest that patients who are diagnosed with chronic myeloid leukemia live a normal life, really. They have a fairly normal life expectancy on therapy, and for a reasonable proportion of those patients, we can now take them off of drug. For our children with leukemia, who are an incredibly resilient bunch of patients, many of those do very well, and that's because we can treat them with incredibly intensive chemotherapy and cure them of their disease. But the long-term effects of that, we're only now realising. It's a funny benefit of this job is that as you can treat and save more patients, you actually then have to worry about what happened to them when they were being treated, because now they're long-term survivors and there are downstream consequences.
Speaking of children, is there an emotional difference for you from a research perspective, researching cancers that affect thousands of children compared to other cancers?
I think I always said when I started working this area, I'd never work with children or in childhood disease. I found that way too confronting. Of course, I now do a large proportion of that. I think if you see a young child, or if you receive a sample in a lab of a young child who has been diagnosed with leukemia or any form of cancer, there's a huge amount of empathy. I mean, it's not only what the hell did that kid do to deserve that, but how are the parents? So it's sort of a double whammy situation. And I think, so the youngest baby that we've ever sequenced was 36 weeks gestation, and they were born with leukemia. That hit everyone in the lab because it's the youngest child we've ever seen. So yes, there's an emotional, but every patient's got a story, and every patient has a family, and there are always people that are going to be affected by it. But I think with children, particularly very young children, it kind of defies the odds of what we think. We talk a lot about preventing cancer. We talk a lot about the things you should do to live healthy lives, and they're all true. But, 36-week gestation baby hasn't done anything in their life that's going to actually cause the cancer. So, yes, there's a huge amount of, pressure, I guess, in actually improving things, understanding that disease and seeing what can be done.
Do you get opportunities to meet patients and their families?
Not so much. So when I first started, way back, as you said, decades ago, we used to go and bleed the patients. So it was your job to come in early in the morning and go over and bleed patients. So you got to see them. And there were a lot of tests in those days that were done on patients. So you didn't just take blood, you actually did tests on patients. So we used to see them, and not necessarily these days, but, occasionally you do. And if you go over to women's and children's and the opportunities there, usually one of the clinicians will say, oh, do you want to come and meet such and such? Or this is the person who diagnosed your leukemia or who did the sequencing. So, yeah.
What's that like?
They only do that to the patients who are doing really well. So it's actually really positive. You feel like you've made a positive change then. We don't sort of get marched into intensive care, of course, but if they're just sort of sitting in the ward or playing or just, that's a really nice feeling.
And does it play on your mind when you're not making as much progress as you'd like or you're getting frustrated?
Plays on our mind, I think, when we don't understand what we're dealing with. So in some cases, we've come so far in the way that we understand and can diagnose leukemia or acute lymphoblastic leukemia, which is my area of specialty. But there are some cases that you sort of open up the files off of the sequencer, look at them and think, oh, what is this? And you can't find anything. They're rarer and rarer because we're getting better and better at what we do. And it's a worldwide effort to characterise cancers. So I don't think eventually that will be a very rare event. It's certainly becoming rarer. But, because I interact with so many different groups around Australia, we often know the background story to the child that we're looking at or even the adult. And it's always Murphy's Law, I guess, that patient that someone's rung you about and said, I don't know what this is. Can we send it over? The patient's not doing so well is the one that you actually have trouble diagnosing. And so that's the one that you have to make a phone call and say, we can't work out what it is. And, ironically, you can often go back. So we've had a couple of cases just recently where we've gone back and looked again and actually then been able to understand the disease. It didn't help that patient, but it did help the next patient.
And that's part of what fascinates you about it. I would intuit that you can never have all the answers and there's always something new to learn as you're going along. And that's it, double-edged sword in that that's terrible and it costs people their lives, but also you get to work things out that are going to really make a massive difference.
Yeah, I think we haven't solved the mystery. And I don't think we will in my lifetime, but we will, certainly lifetime as a researcher, but we're getting closer and closer. And I think the collaborative strength of the research is great in Australia. So there is a lot of efforts to understand what those rare subtypes look like. Is it, and I think you don't go into research because you like doing the same thing every day. So we're all inquisitive, and there are things when we can't actually diagnose patients. What's really good about that is that, or from a laboratory point of view, is that it makes us dig deeper and try and develop new assays in order to understand the disease. And that helps. That really works. And it stimulates us as well. It makes us try and understand what else we can do to deal with the disease.
Why did you choose cancer research?
Oh, I think it chose me. I didn't have any intention of actually, from school I applied, I won't make it that long, trust me, too many decades, but from school I probably wanted to do medicine or science, but I didn't really know what I wanted to do in science. And it was I decided that I probably didn't want to go on straight away. So I had all my university offers, wasn't really sure which one I would take. There was a opportunity to do some holiday work at what was then Institute of Medical and Veterinary Science, so IMVS, which was on Frome Road. And I applied for one of those positions and got it. In the meantime, Year 12 results came out, etc. And they said, well, what department do you want to work in? What departments are there? And haematology sounded better than microbiology because I figured microbiology probably smelt. And so I'm not great with smells. Yeah. And so I chose haematology and did routine haematology for a number of years, moved into research. Tim arrived, moved into chronic myeloid leukemia research, but always wanted to be, I think I'm easily bored really. So always wanted to do something different. which is probably why there's still that excitement value and not knowing everything we can possibly know as yet about the disease. So cancer came along because haematology is, the cancer of haematology is leukemia. I didn't ever define that I wanted to work in cancer research, but I knew probably within a couple of years of starting as a trainee that I didn't really want to do non-malignant work. It was actually working in and understanding a disease that was really what I wanted to do in a malignant sort of setting, I guess. So.
And you're our precision cancer medicine theme leader now. What's it taken to get to that point in your career?
Lots of years, I think. Not particularly. I think I feel, for me, it was never the aim to actually become the precision medicine cancer medicine theme leader. It'd be good if I knew
We'll say that one again.
Precision cancer medicine theme leader. But I think in the end, what that sort of role does is, one, it lets you have a little bit of influence about the way things are travelling within the discipline. It also takes the pressure off of some of the younger people in doing those sorts of roles. So this sounds altruistic, and I don't mean it to be, but, it is a bit about giving back and making sure that everything is going ahead okay and that the researchers can do their research. So it's an advocacy role as much as anything.
What's your approach to leadership?
My approach to leadership really is to understand what people want to achieve, understand what we need to achieve, and talk about getting the two together. And sometimes that's not easy. The staff that we employ, and particularly the students we have, are quite different to what they were when I was a PhD student and an honours student. And so it really is a matter of making sure that the people you have in your team they all have their own individual ideas, but they actually have the end game in sight, I think. It's not, we talked about medicine earlier. It's not a job where it's 9 to 5, as you would have witnessed. We have people who are in 7 in the morning.
And even when you're not there, it's just still going through your head.
Yeah. I do a lot of work at home. I think it's really important you don't want to push people into the ground by any stretch of the imagination, but you want people who are really keen to do what they want to do and see how far they can go. And those people stand out. The people who don't want to do that, they still have a role. I mean, some of the technicians, etc., the people who handle the clinical trial samples, who may not necessarily be researchers, they all are really critically important. And it's a matter of working through everything. And don't forget, by the time you get to the stage that you've got a PhD, you've been in the game for quite a while. And so the challenge is keeping everyone balanced, I think. But we have a pretty good team down there.
How are researchers coming through now different to in previous years?
So we have PhD students in our group, for example, that did their degree under lockdown. So we had to teach them to actually hold a pipette. The sort of stuff that you learn first year university is now being taught when you're at the postgrad level, honours or PhD. And so that's different. They come through with different, and I think this is a good thing, although management-wise can be difficult. They come through often with many set ideas on what they want to do. I tended, and I'm not sure I know which way is right, but I tended to always thought that if you did a reasonable job, you'd get somewhere and you would move through and opportunities would arise. I have students now who have their whole life mapped out in front of them. And I worry that that's a recipe for failure, because things never go that way, and you also miss opportunities if you're so set in your ways on what you want to achieve.
Have their life mapped out in terms of what they hope is going to happen.
Yeah, or what they need to happen. Yeah. I need to do this. I need to finish this now because I need to be here then and there. It's like, wow, okay. Yeah. I wish I was that organised, but I'm not quite even now.
We know that everything doesn't go to plan.
Yeah.
It doesn't mean that having a plan's a bad thing, but yeah.
And but I think, I have, what have I got? I had 26 PhD students that I've supervised. It's because you do learn a lot from them and accept that they're different. And I've had children, so I think that helps. I've been through the teenage and early 20 phase. So I think you've got to sit back as a supervisor and actually say, this is give and take. There are things that are deal breakers for me, and they'll be deal breakers for the university. But you need to let us know where your limits are as well and what you want to achieve. So it's good. We usually have, if you're up on level 8 on a Friday afternoon, you'll hear the laughter coming from the room when we have our student meetings.
You've got some brilliant young people under you. What encourages you most about the next generation?
Oh, some of them are really exciting. Some of them work. Some of them have really innovative ideas, much more innovative ideas than I ever had, I think. And they drive those ideas into practice, which I find really exciting. This group of students have resources at their students and postdocs have resources available to them that we only ever dreamt of. So, or in fact, to be honest, didn't dream of. I've often said, I'm pretty sure we never learned that at uni. On a number of occasions, because some of the protein work that we do now, we didn't even know the proteins.
In terms of the technology for proteomics and genomics, that sort of thing.
Yep. And these guys get to learn that through their degrees, depending on what sort of degree they do. So they come in fully armed with, well, we can just do that. Good. Can you show me? That's pretty exciting. To think that sort of technology is being taught at the undergraduate level and then can be brought straight into the sort of clinical translational research space. So
we just have to be able to afford the technology.
Yeah, that's the sad part, isn't it?
It's an ongoing process.
Yeah, indeed.
But we do have a lot of cutting edge stuff at SAHMRI that people can apply this knowledge that they're learning and then actually come to SAHMRI and they have at their disposal what they need to be able to make those strides.
We do. We're very privileged, and we're privileged really across the precinct as well that there is much cutting edge equipment. So if we don't have it, someone else does, and we're pretty good at sharing and moving around. Most of that stuff's really expensive, and it's expensive to run that equipment, but it's critically important.
It makes everything so much faster.
Yeah.
From when you started to now in terms of how quickly you can get results.
I remember to look at one single gene when I started my PhD, it was about 3-day assay, and then we use X-ray. So you'd use radiation in order to incorporate radiation into the gene. We'd gene sequence them, and then we'd put those files down into minus 80-degree freezers. So like developing a Kodak film. And that could take 2 to 3 weeks. Now, you'd made one change in that time, and it took you 3 weeks to work out whether that one change had made the assay work or not. These days, we change it again the next day, and the next day we can read stuff out so quickly. So technology's improved so much and gotten much faster. Does that make it easier for us to be competitive? Well, we have to be that fast to be competitive. I think that's the real thing and the real advantage of being at a place like SAHMRI. We do have that technology where we can be competitive.
And exciting that the technology is only going to get faster.
Hard to believe.
And probably a lot faster, a lot quicker than it even has in recent years.
The downside of that is that the sort of things that we see coming off of this sort of equipment now, you can't just look at it and see what the result is. We need teams of bioinformaticians, biostatisticians to actually analyse that data first before we see it, because it comes off as a series of code, particularly when we're talking about sequencing. But yeah, you can do an assay now and go home and analyse it that night. Not necessarily in genomics, but certainly in a lot of other stuff that we'd be waiting weeks for. So that's exciting. It also puts the pressure back. So it's a different change. It's a change in dynamic, I guess, in the way you look at that and manage it.
And you've also had the opportunity to collaborate a bit with one of your sons, who himself is a researcher. What's that like as a parent?
It's actually really great. And I think my attitude to it at the time, so I don't know how much time we've got, but I had a phone call from a collaborator that I have in Perth who was talking away, and he said, "Oh, by the way, I need to ask you about somebody. He's applied for a job here, and I think he's going to come next year because we've probably chosen him. His name's Daniel White." And I went, and he went, Oh, now I've said that out loud. I've just realised. He said, "Is he your nephew or something?" I said, "No, he'd be my son." So he's a clinician. So he's a paediatric oncologist. At that stage, he was still training, and it's been a process really of letting him find his way to us, if you know what I mean. So we've never really forced. I've certainly never forced he get involved in what we do, but it's happened organically. And so many people, I rang someone at Women's and Children's last week and said, "We probably need someone to do this, this and that." And I went, "Have you spoken to your son?" "Well, I reckon you should be the ones that talk to my son." Because, so I'm not, saying, "Can you throw the washing on, mate?" I'm, talking about a fairly large project here. And so it's been really well accepted across the community, particularly across the paediatric community, that we both work in the field. And he's adapted to it better than I would have, I think. I think I would have found it confronting, maybe, but it's great. It's been really good, actually.
That's such a special thing. You must be proud of him.
Yeah.
Have some moments of like, I made you and now we do this together.
Well, I said to him the other day, "Look, I'm running this meeting. You might want to call in, because I think David Jung might actually ask you to step up to the plate on this one." He turned up, and one of the guys from Queensland just said to me, "He must be so proud of you. You just threw this meeting together." And I went, "And I'm pretty proud of him as well." Yeah. And it's sort of, it's nice, but we talked a lot about science and medicine, as the kids were growing up, much to my husband's disgust. And it's obviously subliminally gone in, but we don't talk a lot about it now. So if we, have lunch together, we don't have a big chat about work. But he's obviously, I think the thing that's most pleasing to me is he's really happy to be engaged and doesn't sort of go, "Oh, really? You want me to work with my mother?" We don't hear that.
That's
so
because
cool.
He came to you.
Yeah, it's because I didn't say, "You need to do this with us."
No, we get sick of that as sons. On that, how do you get some space outside of work?
It's the longest pregnant pause you've had the whole time, isn't it, really? Space outside of work, 3 grandchildren, 2 dogs, big garden, husband. There are good things that happen outside of work where we can shut down. I think you're probably asking at the wrong time, because we've just come out of grant season, so I still feel absolutely slammed.
So you're emerging.
Yeah, no, I'm not quite there yet. I still feel a little damaged, but that will come back. But to be honest, this isn't a 9-to-5 job, and fortunately, my husband doesn't work a 9-to-5 job either. It's not a 9-to-5 job 5 days a week. It never has been. It never will be. I do try and quarantine time, and there are things I love doing. Seeing my family. I have a son in Melbourne means that we get to go over there.
Any hobbies?
Varies. A bit fickle when it comes to, sometimes I like knitting, and everyone goes, "You knit?"
You go through phases.
Yeah, I'm very, very phasey when it comes to that sort of stuff.
My girlfriend does crochet at the moment.
Yeah. I actually saw some stuff online the other day, and I went, "I might buy that." Then I opened another cupboard and saw a whole big box of wool and went, "Maybe I should use that first." It depends what mood I'm in. Reading, I read every night. I like reading. I read trash frequently.
You're a fiction or non-fiction?
I prefer fiction, because I tend to work till quite late at night, and I do a lot of work with people overseas. So I'm online till quite late at night. I need trash to put me to sleep.
Escapism.
Yeah.
I get that.
So I don't, and on a plane, I'll read shocking stuff just to sort of relax me. So I love reading.
Murder mysteries.
I like listening to. I know. I went back and read one not that long ago. It was a pretty treacherous sort of story that I didn't anticipate where it was going. I didn't sleep. It's like, God, why do people read this stuff?
You read it.
But fickle. Like a bit of a foodie. In fact, a lot of a foodie. Love going to wineries, doing all that. That would be, if we get a free weekend, take off.
You got to carve out a bit of time for the important things.
Yeah. I do enjoy the good things in life, but you got to work hard to get that these days. So, take the good with the bad.
And what is it about SAHMRI that's kept you at the institute?
I think it's not completely ensconced in red tape. We have flexibility. We've had the ability to bring the people in that we wanted to bring in within the confines of money. It has a very forward-thinking attitude, I think. I've got along really well with both directors, which helps. So having EDs who are different, but actually come up with some. They're very supportive. I think that's been really good. I didn't particularly want to go back full time, although I'm still very associated with the university. Didn't want to go full time into the universities, nor full time into the health system. So back into the Callan or the RA, which is obviously where I came from. Really, SA pathology, part of all of that. So I've really enjoyed it. I really enjoy being at SAHMRI. I mean, every job has its days, but I actually really enjoy being there. I think I've had plenty of opportunities to go elsewhere and have decided that Adelaide's my home and SAHMRI's where I work. My other home actually is probably a better way of putting it.
Any retirement plan, or are you going to do this till the wheels fall off?
Yeah, it's one thing that Dan said to me that, Mum, when are you retiring? Not at the moment. Well, yes, it's in the... It'll happen. I'm not going to do it till the wheel falls off. I hope, but, I could be getting to that age now where, that's out of control. I don't want... I haven't exactly planned what I want to do yet, and that's part of the problem. So a couple of things. One, I've got unfinished business. It's at work and with the team. So there's lots of things I want to do with them and make sure safe, secure moving forward before I go. Second, I don't know what I want to do when I finish. One can only spend so much time sitting at wineries and eating cheese and knitting. So you've kind of got to, there's a few things that I'd like to ultimately do probably. I suspect what I'll do is step down slowly, because I don't think you can go from this sort of job to zero. I think
there's only so many murder mysteries you can read at once.
You can keep yourself awake for 3 nights in a row. That would be a good plan. But I think you need, for me, and everyone's different, I've got to have a plan, and it probably will be, in a couple of years starting to say, okay, I can't work full time anymore. I need to slow it down and do other things. Mm. And I think that's probably the way it would work for most people in my position, rather than, from 100 to 0 would be really hard.
Well, we'll be lucky to have you as long as you stick around.
Yeah. In my wheelchair.
If that's what it takes. You can do research in your wheelchair. It doesn't bother us.
You can move around in SAHMRI very well in a wheelchair,
right.
Actually. So, but no, I'm aiming not to be. There's got to be something different outside of life. But at the moment, I still love it. As much as I probably come across as grumpy and miserable sometimes.
No, I can tell that you love it.
It's what I'm really lucky to have found a career that I really love and want to, and at the moment want to keep doing.
And society's lucky too. Thanks, Deb.
Thank you.
If you want to learn more about SAHMRI and the researchers working to build a brighter, healthier future for you and your family, head to samhri.org.au.